Good evening, everyone. Welcome to our webinar this evening. Some of you may know me. I'm Lucy Meehan. I'm one of the radiologists here at VetCT. We're very lucky this evening to have Jonathan Dixon joining us. Jonathan's one of the clinical radiologists at Rainbow Equine Hospital in Malton in Yorkshire in the UK. Rainbow has a very excellent reputation for being early adopters of new imaging technology, and we are very lucky that Jonathan has been able to join us tonight to share his experiences with being one of the first centres in the UK to have a wide bore CT that's allowed them to image necks. I'll just switch presentations over. Just a few housekeeping bits to start with. If everyone could stay on mute for the duration of the webinar, that would be great. We do have, if everyone's familiar with Zoom, at the bottom in the center of your screen, there is a chat box. If you'd like to ask any questions, and questions are really welcomed throughout the webinar, if you'd like to ask any questions, please just type those in the chat box, and we'll have some time for questions at the end. But if there is anything pertinent, one of us will be monitoring the chat box throughout the webinar, so we will be able to answer those questions as we go along. I think that was everything I had to cover. So without further ado, we will get started. So the title of our webinar tonight is "What does advanced imaging teach us about neck radiography?" So what we wanted to do with this webinar is to look at radiographs, look at the radiographic anatomy of the neck, and look at what views and what pathology we can see, and then talk about CT, when we consider CT and why we might consider CT. Jonathan's going to talk a little bit about the techniques that they use there and what pathology they're seeing on CT that we may or may not see radiographically. And then we're going to have a little bit of a sort of circle back to radiographs and talk about what CT has taught us about radiographs and what has changed when we're looking at radiographs since the advent of CT of the neck. So I'll just start by talking a little bit of a brief overview of neck imaging. So it's a really common thing that most of us do. There are various reasons for doing this, from horses that are presenting with neck pain, ataxia, lameness, unresolved forelimb lameness in particular. And we often take radiographs of these horses of the neck, sometimes because for owner pressure, sometimes because we are that this is the last thing we've got to image, and sometimes obviously trying to solve a problem with ataxia. So we know that interpretation of these radiographs can be challenging. Often we've only got lateral views. There is a lot of complex superimposition in this region. You've got two articular process joints that are summed into one on a lateral view. And frequently when we're doing this, we're actually in quite a high pressure situation. We're often it's an ataxic horse. We're often making big decisions about this horse's future on this set of radiographs. So any way we can get any more information is very useful, in my opinion, anyway. So if we think about our lateral radiographs, most of us are familiar with these. Most of us spend an awful lot of time looking at them, but let's just take a step back and actually think about what we want out of these and how to get the best out of our lateral radiographs. So for me, a set of lateral radiographs should extend from the poll, which is slightly cut off in this image. I have to admit, I would prefer it to be a little bit further cranial, and right down to the cervicothoracic junction down here, C7 to T1. And most high-powered gantry systems with a DR plate will give us that level of detail at that at the cervicothoracic junction. We usually have between 4 and 5 images, depending on the size of your imaging plate. So it's quite often that we will have C1 and 2 on one plate, part of C2, 3 and 4 on another, and then sort of have to piece everything together. I think it's really quite important to, although I don't create this image every time, to actually go through and check and count my vertebrae and check I've got every vertebrae. That is a little bit more challenging with 3, 4, and 5 because they look very, very similar. We know when we're at C6, we've got this additional ventral process that we can see on C6. It looks like it's wearing a little skirt, which is quite handy for identifying. But I think it's really important that we take the time, take the step back, and actually count and check we've actually got everything we need to look at. The next thing I do when I'm doing a set of lateral radiographs is I start by looking at the transverse processes of C3, C4, and C5, and I assess these as to how close they are because I'm checking whether or not the images are oblique. I'll hold my hands up and say this one's not perfect. We've got a little bit of obliquity here and a little bit of obliquity here, but it's as near as we can expect often. Next thing is to check our joints. So I start with looking at the atlanto-occipital joint, check that's smooth, check that's regular, check that's all fine. Often as well, looking at where the dens sits into the atlas, because that can be an area that we can see issues. And then I'm looking at my articular process joints, checking them for size, shape, regularity, and margination. Looking at my vertebral canal, checking that that's smooth, regular, that there's no big steps in there, that there's no changes in angulation of our vertebral canal. So that's sort of how I would approach a set of lateral radiographs. They don't all look the same. There is a degree of normal variation in there. So occasionally the ventral process of C6 can be transposed onto C7. So we can see this is a young horse. We've got our open physis. This is C6, believe me, I counted them many times. We've got a normal looking, so a C5 type looking set of transverse processes here. Then when we look at C7, we can see that that's got an extended ventral transverse process. This can be unilateral if we look at the image ventral to that. If we look at the image below that, you can see we've got one nice normal transverse process with a ventral spur, a ventral process, and then we've got another line going up here, which indicates that that's probably unilaterally transposed onto C7. The other normal variation that we see quite a lot and can catch people out, and certainly has caught me out in the past, is that we have a small vestigial spinous process of C7, and that can be fairly small. It can be fairly difficult to spot, and it can look like we've got periarticular bone or a fragment. So just do be aware of those as a normal variation. There is quite a nice study that came out a couple of years ago looking at cervical vertebral morphological variation, talking about the C6 transverse processes, and that's not been associated with clinical signs. The next thing to think about is our oblique images. So if we talk about these for a moment, now these are really very, very useful, and they are something that I do. I wouldn't think I had a complete set of neck radiographs without having looked at these. However, I will hold my hands up and say that they are relatively challenging to learn to take initially, and I'm sure I have a flock of interns and residents who will tell you that they've spent a lot of time trying to get these to my satisfaction, and possibly may have been cursing me slightly whilst they were trying to learn to do them. But it is definitely worth persevering. The technique's really well described in this paper from 2009, but just very, very briefly, we're taking ventrolateral to dorsolateral obliques. So our generator is positioned ventrally, angled dorsally, and our detector is positioned perpendicular to the X-ray beam. The angle varies between 45 and 55 degrees, so it's a slightly steeper angle further cranially and a slightly shallower angle further caudally, which reflects how the articular process joints change as we go from cranial to caudal. And we also need to make sure we obtain these from both sides, because that allows visualization of the articular process joints and assessment of whether or not they're symmetrical. The other point to make sure is to make sure that we're labeling these images, because you can get very mixed up very, very quickly if they're not labeled. So if we just think about how these look, this is a transverse CT image, and we're going to take a left ventral to right dorsal oblique. So our detector is up here at the right side of the horse. Our generator is down here at the left side. This red line represents our X-ray beam here, which goes straight through our articular process joint. How does this look? Well, actually, our articular process joint nearest to the plate, you can see our beam goes straight through. And on the radiograph, that gives us this appearance of shooting straight through the articular process joint. The articular process joint furthest from the plate is then the X-ray beam passes around its margins, so we get the circular Mickey Mouse ear appearance of our articular process joints. So that's how these should look. You should be able to see straight through one, and then the other one should be a nice round structure. This is how sometimes they look. This is an oblique that hasn't got sufficient angulation. So we've got our articular process joint closest to the plate here, and then our dorsal one, which is the one furthest from the plate here. And all that needs to happen is this needs to be a slightly steeper angle to separate those out, and then we'll have the perfect image. So don't be disheartened if it takes a while to learn how to take these. It really is worthwhile, and they are very, very useful. So we'll start by talking about some pathology. So we're going to focus on the more common pathology that we see. So we'll start by talking about cervical vertebral malformation, which is, I'm sure you're all aware, a common cause of ataxia in young horses. It's probably the most common cause that we see in Europe. Obviously, infectious myopathies occur in other geographical areas, so we do have to be mindful of those, certainly if we're reading films from areas where those are endemic. So when we're talking about cervical vertebral malformation, or CVM, we're talking about narrowing of the vertebral canal in combination with malformation of the cervical vertebrae. And that causes stenosis of the vertebral canal and compression of the spinal cord. Most commonly, the spinal cord is compressed at either C3, 4, 5, 6, or 6, 7. And usually, so these can be dynamic or static. And usually we're only looking at static images, which can make life more challenging. So subjectively, so we would always look at these subjectively first. So we'd look at our plain films, and we're looking for signs of flaring of the caudal vertebral physis, which is indicated by this white arrow here. Caudal extension of the dorsal lamina, so we can see these little asterisks, which are showing us our caudal lamina is extending over the vertebral body, caudal to the articular process, caudal to the vertebrae. So it's more obvious here at this C4-5. Malalignment of the vertebral canal, so we can see that this vertebral canal here is funnel shaped cranially, it almost looks narrowed, and you can see it widening out further caudally. And we often see this in conjunction with enlargement of the articular process joints. We know that subjective evaluation doesn't discriminate. It has been found not to be discriminatory between horses with cervical vertebral malformation. So we know we have false positives and false negatives, even in clinical cases. So the subjective indicators do increase our index of suspicion, but they're not diagnostic in their own right. So what else can we do? Well, we can do semi-quantitative measurements. So these are commonly known as inter and intravertebral ratios, and we commonly calculate those in the neck. So just briefly as to how we calculate them. So our intervertebral ratio is the narrowest point of the vertebral canal. So we take the dimension of the narrowest point, and that could be anywhere along the vertebral canal within that vertebral body. And we divide that by the height of the vertebral body at its widest point. So A over B is our intravertebral ratio. Intervertebral ratios, those are the shortest distance between the caudal point of the more cranial vertebra and the dorsal lamina of the more caudal vertebra, or the cranial point of the caudal vertebra and the dorsal lamina of the cranial vertebra. Whichever is the shortest of those distances, we divide over the height of the vertebral body, and that gives us our ratio. The important thing to remember with these ratios is that any ratio of less than 0.485 is indicative of cervical vertebral malformation, but this doesn't necessarily indicate which site is compressed, so it could actually be anywhere along the vertebral canal. There's just a few points to remember when we're talking about these ratios. Is actually there is evidence that the inter and intravertebral ratios together are more sensitive than using either on their own, but there is a wide variety of inter and intra-operator variability, and it can be as much as 10%. So in practice, what this means is that I would normally measure all of these 2 or 3 times, take the average, and then report sort of the average of those, rather than just measuring once and thinking, oh, everything's fine. So I think it's a useful thing to know that actually there is inter and intra-operator variability. If it looks like it should be compressed and it's not, probably measure again, take an average of your measurements. The sensitivity and specificity for these measurements on top of plain radiography has been reported to be as high as 78%, but some have reported it as low as 47%. So it's not the be all and end all, but it does help us get an answer over and above what we see from plain radiography. Our next option, if we're fairly convinced there is a problem and we want to find out where, is to do myography. So this is commonly performed under general anaesthesia. I'm not going to go over the technique in any detail. Suffice to say, we inject contrast at the atlanto-occipital space. We acquire lateral images in neutral, hyperextended and hyperflex position, and we're aiming to detect dynamic and static compression, which is why we do move the neck around whilst we're doing these. So we evaluate our lateral radiographs. So this is an image of a myelogram, which is fairly normal. We can see we've got a dorsal contrast column going along here, and we've got a ventral contrast column along the ventral aspect. These little deviations in the ventral contrast column are perfectly normal. That's where the intervertebral discs are. It's mainly our dorsal contrast column that we're interested in. So we talk about what signs we use to be indicative of compression. So first of all, we talk about reduction in the total dural diameter. So that's the diameter from the ventral aspect of the contrast column to the dorsal aspect of the contrast column. And a reduction of that by 20%, by more than 20%, is considered indicative of compression. A reduction in the dorsal myographic column by more than 50%, so a reduction here by more than 50% is also considered significant. There is some evidence that a reduction in the dorsal myographic column to less than 2 millimeters is significant, but actually that is the least reliable of these measurements, and it can be very variable and depending on the size of the horse, depending on the position of the neck. So that's not one that I would use commonly. I'd normally use the first two. We have talked about the fact that our imaging has got better. We're more able to detect things further caudal in the neck, so the cervicothoracic junction, and we do know that slightly different rules apply there. So we would talk about the reduction in the dural diameter by more than 30% in that region, and the reduction in the dorsal myographic column by more than 60% to be significant. If we just look at a myelogram with some significant compression, so this is an 8-year-old gelding that had a 3-week history of ataxia, and we can see that we've got the C6, C7 region here. We've got an X-ray taken in neutral position on the left, and then one taken in extended position on the right. And if we look at our dorsal contrast column here as we're going through, we can see that that does narrow here at C6, C7 in our neutral view, and we can see that narrows much, much more and almost disappears in our extended view. And if we do the measurements for that, we can see that our dorsal myographic column in the neutral view reduced by about 40%, whereas in the extended view it was over 60% reduction, and our dural diameter in the neutral view that reduced by about 15% in neutral and 22% in the extended view. So this horse was confirmed to have a compressive lesion at C6, C7 based on the myelogram. If we think about other things that we see quite a lot in horses, articulated process joint osteoarthropathy is fairly frequent. We can see it as a cause of ataxia in older horses. It also can be seen in conjunction with neck pain, neck stiffness, and there is some nice work that's come out of Sue Dyson's group talking about a postulated link with forelimb lameness. So we do just need to be mindful in all of these cases that this may be causing a problem. Well, if we look at the radiograph on the right here, we have got some enlargement here of C5, C6. So you can see that it's extending ventrally a little bit closer to the dorsal border of the vertebral body than I would expect. And if we look at C6, C7, we can see that that is much more evident at this level. There is a little spinous process C7 here, but I think there is also some dorsal new bone there as well. And we've lost visibility of our intervertebral foramen. Now it's a little bit difficult because we do get superimposition with the positioning of the articulated process joint over the intervertebral foramen. So we can't really say that that's narrowed, but I think there is definitely obstruction of our visibility of the intervertebral foramen. But how significant is this? Because we know it's a common finding in horses with caudal neck Sorry, it's a common finding through radiographing horses' necks. We know that there's been a few studies done that have shown that the size of these articular process joints may increase either with age or just as you go further caudally. There's a really nice study done in 2009 out of Cambridge, which showed that in horses with poor performance, a lot of horses had increasing size of the articular process joints further caudally. And this study, which has recently come out of Florida, the Espinosa Moore, which showed that actually quite a high proportion of these warblers that are show jumping at a very high level had a reasonable amount of enlargement of our C5, C6 and C6, C7. So we know that this is fairly prevalent. They suspect that that's not causing a problem for performance. So how do we determine whether or not these are relevant? So to me, for certainly a forelimb lameness, it's a diagnosis of exclusion. So I'd want to know that the leg had been blocked all the way up and that we'd done other imaging. And this was, our articular process joint was, what we thought was the problem because we'd excluded everything else. We talk about doing treatment trials, so medicating these articular process joints and giving the horse an exercise program and seeing if we get a recovery. The other thing that we sometimes talk about, which is in red here, because it's a little bit contentious, is blocking these articular process joints. Certainly, it's one of those things that people talk about doing. I haven't done it myself, but I do know a lot of people that have, and have said that they have had good results in that these horses that have been lame previously have been sound. Jonathan's got some really interesting images to share with us later, which may query whether or not we're actually going to be able to block the pain that is caused with these when we've got these big articular process joints and narrowing of the intervertebral foramen. But I think it's something that definitely needs to be developed in the future. So if we just go back to this lateral, this is an 8-year-old event horse that, sorry, 13-year-old event horse that came in with a history of patchy sweating on one side of the neck. The horse was performing fine. It was just the patchy sweating. We can see that our C6, C7 articular process joint is quite enlarged. We've got ventral extension here over the dorsal part of the vertebral body. These are the obliques from this horse, and I think it's really interesting because the changes are asymmetrical. So this is our left ventral right dorsal oblique. So this is our right articular process joint here ventrally and our left articular process joint here dorsally. And we can see we've got some periarticular new bone formation here, which we're not seeing when we look at the same joint on the other side. You can also see a little bit of new bone formation here and some lipping, which isn't present on the other side. So it was interesting to me that this horse just had patchy sweating on the left side of the neck and had asymmetrical enlargement of the articular process joints, which apparently was not affecting his performance. One of the last things I need to talk to you about is articular process joint fragmentation. We are seeing this increasingly reported. There's been sort of groundswell of literature over the last few years reporting articular process joint fragmentation and talking about treatments for this. We know that we see it in association with articular process joint enlargement. This is a lateral view, and we can see our fragment quite nicely here at C3, C4. So you can see them on lateral views, but actually, in my experience, they're usually difficult to pick up on the lateral views, and we do normally require oblique views. And I wanted to mention this, I think it's important to consider these as a differential, certainly in horses that are ataxic or in horses that have got abnormally enlarged articular process joints where you suspect there's a degree of asymmetry. Actually, once you go looking for these, you do seem to find more and more of them. So I think it's something that definitely perhaps was being underinterpreted previously. Just a quick word about the origin of the fragments. We don't really know where they come from. OCD is considered possible, trauma is considered possible, but we're really not sure. And there's a really nice paper that came out of Liphook just before Christmas talking about articular process joint fragmentation, which I think Jonathan's going to cover in a little bit more detail later. So this is the oblique of this horse. So we can see this is a left ventral right dorsal oblique. So this is a left-sided fragment, but it's not really possible to tell whether it's dorsal or ventral within the articular process joint, and it's not really possible to tell whether it's medially or laterally located. And all of these things have connotations for prognosis. So the last thing I want to talk to you about is fractures. So we do occasionally see fractures of the cervical vertebrae and of the transverse processes, like in the image on the right here. They're usually visible radiographically, but it can be difficult to determine the extent of the fractures because of complex superimposition. So in this horse, you can see on the lateral, there is a tiny little vertical radiolucent line here, and possibly a little bit of mottling of the cranial portion of this transverse process. I've been a bit naughty, I've cut off C3 and C4, but the x-rays didn't look very exciting, just the plain laterals. And when we look at the oblique, we can see that we have got a comminuted transverse process fracture of C5, which extends forward into C4 and C3. So we've massively underestimated the fracture just from the lateral views. The other type of fracture that we see sometimes is an articular process fracture, so sort of cranial articular process stroke dorsal laminar fracture here. And these can be important to make sure that we monitor these healing, because you can get fairly proliferative callus formation here in these horses. So that was all I wanted to talk to you about radiography. We'll come back and summarize that at the end. Jonathan's now going to take over and talk to us a little bit about CT. I think you can probably guess from this slide what his attitude to CT is, but I'll hand you over to Jonathan now.
Okay, good evening everybody in the UK, and good morning to those across the pond in the United States and elsewhere. Hopefully you can all hear me okay. And as Lucy says, I think this slide does somewhat depict my overall views on CT of the equine neck. And hopefully I'll come to why in a second, but we will certainly need to acknowledge some of the limitations in what CT can do at this very early stage. Okay, so when I'm thinking about why we consider neck CT in horses, it is partly because of all of the things that Lucy's very carefully explained, including the size of the patient. So we have got genuine physics limitations of what we can achieve using radiography. We've got limitations of ultrasound in terms of access to some of the vital structures in the neck, particularly the spinal cord. And the anatomy is incredibly complex. We do not give it enough credit. You know, left and right articular processes, cranial and caudal, all superimposed on one another when we're trying to evaluate these structures. Genuinely, there is a lot of osseous material to sort of appreciate on a lateral and an oblique radiograph. So we do need to give ourselves a bit of credit that they are complex areas, and sometimes things simply cannot be seen. More importantly, when we're treating these horses in the clinic, we need to remember that pathology is frequently lateralized, and the use of CT has really highlighted that fact. And if we're going to guide treatment to be effective treatment, then potentially knowing exactly where that pathology is and what that pathology is really vital. I would happily acknowledge that if it were a widely available option and realistic to image the entire neck of an adult warm blood horse, then antemortem MRI would almost certainly be the preferred imaging method of choice, particularly for the soft tissues of the neck, but sadly that's just not possible. So the remaining options, CT and CT myography, is almost certainly the best option. And with practice, and I do stress with practice, it is a very rapid test to perform. You know, a horse having a CT examination of the neck and a myelogram, including radiographic projections, realistically less than 30 minutes is very achievable from start to finish. So just really to summarize my absolute reasons why I consider neck CT at all in horses, it's those cases where we have inconclusive radiographs and or ultrasound. It's cases where we know where the problem is, but we have a lack of response to symptomatic treatment or local treatment. In our hospital, it's any cases where we're undergoing myography, where that's financially possible. So we almost exclusively do CT myograms and include radiographic projections rather than just performing a radiographic myelogram alone. And those cases where you've identified on your clinical examination, neurological examination, and your conventional imaging some fairly complex pathology, which certainly is not infrequent, for a greater breadth of understanding of what's going on. How do we do it, I suppose? So the image on the left is just a photograph of a horse undergoing general anesthesia and a CT of the neck in our hospital. And obviously that's a fan beam multi-detector CT, which is what is relatively widely available, both brand new and sort of X from the NHS and other medical suppliers. I've put for completeness a photograph of the Epicure medical cone beam standing CT system. It's not a system that I use and have much experience of. I've seen images of that. I think the reality is that that's a long way away from being a practical system to completely assess some of the things that we're going to look at. And in particular, when we're thinking about myography in the standing horse, I think that raises a number of questions, and I'd be very cautious about that personally. So my presentation really refers to fan beam CT performed under general anaesthesia. So from our perspective, what do we need to accurately do that? Well, we need a patient table when we're setting up a room and putting a CT scanner in that's capable of taking a wide range of horse sizes, up to maximum really of 1,000 kilos, and a hoist system that can allow you to position that horse carefully in the sort of isocenter of your scanner bore. And believe me from experience, if that's not lined up well, your life will be much harder. From the CT perspective, we need a wide bore CT gantry, a minimum of 80 centimeter bore, ideally up to 90 centimeters now. And again, I refer here to multi-detector fan beam CT. And that allows you to basically fit that sort of withers to sternum distance as indicated on the image on the right, where that red open-ended arrow is. That's the limiting factor to getting these horses physically wedged into the scanner to get down to the cervicothoracic junction itself. And that's really, really critical to get down to the base of the neck. What we tend to do is position the horse's head and most of their neck on the human patient gantry, which is typically capable of taking up to about 230 kilos of weight. But it's important that we position the horse and we pad the dependent aspect of the head. The eyes is protected, the eyes protected from corneal ulceration, that sort of thing. And ideally, you want the neck quite straight. And obviously, everyone's away, put a horse in lateral recumbent, so you get a natural sump around C3 to C6, which makes reconstructing those images that little bit more tricky. It doesn't, detract in a significant way. But if you can place a soft pad underneath that part of the neck and just gently align the neck in a neutral sort of flat position, it certainly can be helpful. As Lucy's alluded to already, in terms of performing a myelogram, we typically need to elevate the head neck, and we need to clip and prepare a site to do an allantooccipital synthesis and injection. And of course, they're under general anaesthesia. We do our cases actually under total intravenous anaesthesia. It's rapid, it's safe, but certainly placing an ET tube and inhalational anaesthesia is also very possible. And from a technical perspective, we are imaging a really big, wide part of a horse's neck, particularly down in front of the shoulder blades. So the sort of CT parameters from a radiation perspective are pretty high. It's really important for the staff perspective to have everybody out of the room behind appropriate lead shielding, and just taking that extra bit of care for the members of the team. Now, typically the field of view for the CT scans is around 65 centimeters, so quite a large field of view, basically as wide as the bore will allow, and that's the actual bit that you can reconstruct an image within. And then we reformat those images that are required in a transverse plane in all sorts of different orientations to allow us to view the anatomy and the pathology that's present. I just remind myself here that there is some discussion about the benefits or not to performing a plain CT versus just going straight for a contrast or myographic CT examination. And certainly to start with, in our initial cases, we did perform a non-contrast CT followed by doing a myelogram, as is in this image on the right here, with the horse in the bore of the scanner. It's very readily doable, and obtaining images following myography as well. What we've realized in the vast majority of cases is that that's typically not necessary, and you lose very little from not obtaining a plain scan, and certainly it takes a little bit longer to position the horse and be very careful, obviously, about not touching the bore of the gantry whilst you're aseptically preparing the horse and performing the injection. So we now perform these routinely immediately after induction in the recovery box, obtain some radiographs in flexion and extension to tick that box for dynamic assessment, and then move the horses through, do the CT scan in lateral recumbency, and then recover the horse. And additionally, our anaesthetist certainly feels that that's less stimulation for the horse at the end of the procedure in terms of doing flex and extended projections, which can stimulate that horse immediately prior to going into recovery. So it just seems to work, and certainly is a really rapid technique. I mentioned that we sort of want to be quite careful about our contrast use. So obviously we use a non-ionic iodine-based contrast media, that's absolutely critical. For a radiographic myelogram, it's been long described to remove in an adult horse sort of 50 mils of CSF and replace that with 50 mils of omnipaque, so typically 300 milligrams of iodine per mil. We modified that slightly for our CT population based on that natural sump that's created at the base of the neck. We were getting some dependent pooling around the spinal cord, and we found that actually just diluting that out to 80 mils of total volume with some sterile saline improved our image quality. That's not necessarily the experience of everybody, but it can be a tip if that's something that you're struggling with. And just to mention, obviously, risks of general anesthesia, risks of myography. So there are risks associated with increasing the volume of contrast media. That's why we didn't increase the volume of contrast media in our population. We diluted it with saline, so avoid that specific factor. There are risks of obviously increased general anesthesia time. So again, moving to a situation where you anesthetize the horse and do the myelogram immediately, obtain your radiographs and then your CT, shortens the duration of anesthesia down. So again, limiting the risk to the patient. And it is not infrequent for these horses to become slightly hypothermic afterwards, depending on how you categorize a complication. We were very strict in a study that we recently performed, describing sort of the first 50 or so cases. And that's a fairly frequent complication per se, but it causes the horse very little. That's resolved. Most horses that have neurological deficits that are undergoing CT of the neck, surprisingly, even if their sort of level of ataxia is profound, the vast majority of horses, are no worse for wear for having the procedure done and actually stand up absolutely fine. So it's not something to be sort of particularly scared about doing. It'll come as no surprise that the sort of information that you get from comparing a radiograph to a non-contrast CT and a CT myographic image is vastly altered. So immediately we remove the superimposition of the articular processes and the various other osseous structures, as is depicted here. And I'll move on further to show some sort of examples of more significant pathology. But straight away, if you have a lateralizing lesion, we can understand exactly why it will be much more straightforward to detect using CT at all. Okay, so just a brief comment about multiplanar reconstruction and angling and positioning the horse's head and neck. And the image on the left is a native image acquired in a horse, quite a large horse, so 600 kilo warm blood. And that's a sort of C67 level where the horse's neck has a natural sump from being in lateral recumbency without sufficient padding underneath. And it can be very easy to mistake the fact this horse has significant left-sided articular process joint pathology. Hopefully you can see my mouse here, but this quite significant enlargement, and it looks quite asymmetric compared to the right side. As soon as we straighten that image up, as the three images on the right portion of the screen depicts with the various planar arrows, you can see that pathology is very much symmetrical. This is not a normal site. Clearly, this horse has got enlargement and remodeling of the articular processes, but what we no longer have is an asymmetric compression of the intervertebral foramina size, and we can see that is certainly not a unilateral type of pathology. That's really important, and you can do that nowadays with Horus and other free software off the internet. We should acknowledge the limitations of imaging kind of caudal to T1, just as depicted by this graphic. So this is a sagittal reconstruction of a 4-month-old foal. And we can appreciate that the image quality progressively deteriorates even in an animal of fairly low body size, caudal to that level, simply because of the amount of shoulder and soft tissue musculature and things that are overlying that region. And this is using high output radiation sources anyway. So if we think back to our radiographic interpretation, it stands to a very good reason that we're going to struggle with a low power battery generator to get really high quality images caudal to this site. And we have to think about ways of sort of manipulating the physics with our x-rays to try and sort of get good penetration in this area. So, collimating tightly to reduce scatter, bringing the x-ray generator close to the patient, all really vital and easy tips and tricks. So I'm just going to run over sort of what I call the news so far in terms of the published literature fairly recently on CT myography in horses. There's 3 papers that I think are really quite pertinent and cover really quite a large number of horses. To say this technique's not been available for a long time. And that's in addition to a whole bunch of case reports, case series, and sort of histological and pathological studies talking about various weird and wonderful types of pathologies that we can read about to our heart's content. But I think what's really important is knowing if you are going to image a whole bunch of horses, typical, very standard cases, what are the things that we're going to see, what the spectrum of pathology is, and knowing that the whole breadth of the spectrum allows you to sort of set in your own mind what then becomes a mild or a severe type of case, and that's really, really important. So this is probably a really nice paper come from the group led by Mads Christoffersen at Helsingborg in Sweden. And I've just taken one sort of bar chart out of that manuscript. It's really well worth a read, which is the sort of description of the lesion prevalence at various sites in their sort of 180 horses. And we've got the very sort of clear impression that as we move from the cranial to the caudal portion of the neck, the blue bars here indicate osteoarthritis, and we can see that that becomes more obvious towards the base of the neck in terms of the number of cases, the number of lesions that are present. In addition to that, and again, this is a very warm blood, rich population, a sports horse rich population. The green and the purple bars here indicate the sites on the number of horses for which spinal cord impingement and spinal cord compression were identified. And again, in their population, that was far more frequently seen from C5-6 caudally in the neck. So what they actually described in their paper is that 90% of the lesions that they considered were relevant were actually sort of located caudal to the C5 vertebra. So it really highlights the importance of imaging the entirety of the neck. When we look further into that paper, in 180 horses, that's really quite a large case series for early adoption of this modality. 83% of their caseload had evidence of osteoarthritis, and 85% of their caseload had evidence of spinal cord compression or spinal cord impingement. And the most frequent site in their group was at C6, C7. And again, that's probably related to the breed and the type of horses that we're seeing. It's important to distinguish that away from a very young, thoroughbred, rich population that we might see in certain parts of the south of England or in the US and other sort of centres. So depending on your population is certainly going to alter the demographic of where and what lesions you see. A very high percentage of horses had significant lesions detected. I would say 85% of horses having spinal cord compression or impingement is really high. And it's interesting, if you look at them, the number of horses that actually presented with neurological deficits in their study was about 52%. So we have to sort of bear in mind that this is an early study like all of the others, and we're still learning about what is significant and what is not. And just to mention the other things that we're seeing, things like fractures or osteochondral fragments and vertebral malformation and malarticulations formed a small percentage of their population. Now, a different type of graphical representation, but basically showing the same thing. This is a study that we performed in 51 horses, published also last year. And this is a case where we looked at the same types of pathology. We graded them from normal, mild, moderate, and severe. And all we're showing here is the cases where we felt the pathology or the finding was moderate or severe. And that allowed for some degree of, yes, that's clearly a normal case, and also mild change may well be within, let's say, the realms of anatomic variation. So all we're looking at in the coloured bars is cases where we thought that was moderate or severe genuine pathology. And this is a similar sort of representation. So what we found here is, again, another warm blood rich population, that we had high numbers of horses with osteoarthritis or degenerative joint disease. And unsurprisingly, the lower down we get in the neck, the higher the grade it was. So the orange bars are what we called severe disease, the blue bars moderate disease. Going with that, again, it won't be a surprise if you have osteoarthritis, you have enlargement and you have remodeling, that then has effects on the size and the appearance of the intervertebral foraminae. So as the grade of osteoarthritis became greater or higher in the base of the neck, then we found more horses where there were abnormalities associated with those intervertebral foraminae. Spinal cord compression was seen in a reasonable percentage of our population as well. So we had 51 horses, and of those, 31 of those had evidence of spinal cord compression on CT. So, you know, talking about sort of 60% or so not quite as high as the paper from Mads Christoffersen's group, but a reasonable percentage. And I'll talk about the comparison to radiography later. Okay, so when we're thinking about the sort of common things, so clearly osteoarthritis, spinal cord compression, those sorts of changes are the things that we're seeing in really high percentages of horses, what are the things that we're looking to identify? So very much with arthritis, it's the same disease in a different space, in a different joint. So we're looking for osteophyte formation, we're looking for enlargement, we're looking for subchondral bone defects, thickening, irregularity, or osteocyst-like lesions. Osteochondral fragments, certainly, as Lucy's alluded to, various types can all be very relevant. And then things specific to the articular process joints in the neck would certainly include intervertebral foramina changes or narrowing, potentially obliteration when the changes are marked. And what we cannot clearly assess on a plain CT, but potentially we can on a CT myelogram, is spinal cord impingement or compression and shape change. Just to come back, one thing from CT to a point that Lucy's already made, and I think it's really relevant for obtaining good quality radiographs. This is just two different horses, a transverse image through a relatively normal articular process joint at C3-4 and C6-7. And what we can see is that the angle of the C3-4 articular process joint, so to take an oblique radiograph through that joint space, we need to be quite steep angling dorsally along the sort of blue line that's shown here. At C67, that angle is far more shallow, and I've just drawn that line again over the image on the left to just depict that angle change that typically I would recommend you do alter your angle as you move caudally down the neck with your oblique radiography to try and optimize that image quality that little bit further. So examples of what I would consider abnormal or pathological processes in terms of osteoarthritis of the articular facets. So we've got on the top left here, we've got an example of osteophyte formation dorsolaterally, and that's quite unilateral. We've got osteophytes ventral and medial. We've got bilateral, relatively mild pathology, but nonetheless fairly evident osteophytes, and that can progress to subchondral bone defects or osteocyst-like lesions, and potentially even significant enlargements, asymmetry, and narrowing towards that intervertebral foramen. If you look very carefully, you can see epidural fat around the left side of the vertebral canal on this image here, and it becomes much more challenging to appreciate that on the right. Obviously, we've got to be very careful interpreting soft tissues without the use of the contrast on CT. But when things get really bad, you can see quite marked arthritic change. You can see quite significant compression or loss of visibility of the intervertebral foramen. And this, all these images relate to the horse that you can see a photograph of on the right. And this horse presented for a right forelimb lameness that had extensive diagnostic anesthesia all over the limb, and the lameness had not been abolished. It was a middle-aged sports horse used for jumping, been lame for a few months. And the CT images here depict fairly nice examples of quite severe right-sided osteoarthritis. There are changes on the left as well, but we can see that associated with that osteoarthritis, we've got some degree of dorsolateral attenuation of the contrast column surrounding the spinal cord on that right side. And we can see that the intervertebral foramen, and this is only one slice, obviously, but you must believe me that kind of scrolling from cranial to caudal, it didn't get much wider than this. So there's certainly changes there. There's a really nice, very recent paper published in Veterinary Comparative Orthopedics and Traumatology, which I think has got the most stunning pictures depicting the regional soft tissue anatomy, the various muscular anatomy and the nervous structures that are exiting the spinal cord and the vertebral canal at this level. And these are really vital structures that ultimately are going to form significant components of our limb sensation. And it stands to very good reason that these can be associated with the cause of lameness. So I'll just explain for this horse. So this horse did not have diagnostic anesthesia. It'd be a really nice case to perform that in, but sadly, this would not be the client to undertake that process. And this horse did have the right side articular process joints at C5, C6, and C6, C7 medicated with triamcinolone. And the horse's lameness very briefly for a couple of months actually completely resolved. But unsurprisingly, given we're not altering the structural process of what this bone is doing, that lameness recurred, and subsequently the owner didn't elect for any more dramatic surgical interventions, and the horse was euthanized, probably fairly sensibly. But it's nice to know that your corticosteroids can have a brief effect. So as Lucy's already introduced. There's a very recent and really nice paper that's come out of the Equine Hospital group talking about the prevalence of osteochondral fragmentation in the articular process joints or around them in the equine neck. And they demonstrated in 55 horses a prevalence of 24%. So I think it's really high. And I think if we're all honest with ourselves, when we're taking radiographs of horses' necks, I don't think that in approximately 1 in 4 cases where we're picking up osteochondral fragmentation, certainly I would say that I don't. Yet they're there to be seen. And obviously this is a population of horses that have dysfunction associated with the neck. They're suspicious of pathology. It's why it's being imaged, but probably outside of a pre-purchase examination setting, that's the reality in all of our caseloads as well. So again, this is a warm blood or sports horse heavy population, but they're there to be seen. And its question is, how do we pick those up? Interestingly, in 11 of their 13 horses for which osteochondral fragmentation was identified, there were other abnormalities associated with the articular process joint. So what we need to do further work and assess is there a causal relationship between the presence of fragmentation and the development of other joint disease or not. But how does that compare to what was otherwise published in the literature that was already out there? So in our population of slightly smaller number of horses, so 51 horses, we saw osteochondral fragments in 11, so 22%, so very similar. And I suppose both being in the UK, when we have a fairly similar population of horses that we see through the clinic door, that's not a huge surprise. Interestingly, we also saw about 8% of our horses had subchondral bone defects consistent with an osteocyst-like lesion. Now that compares a little bit differently to the group in Sweden, where they noted sort of 6.5% prevalence of fragments or fractures, and unfortunately that information is not broken down any further to extrapolate from there. But either way, if we think about somewhere between 6.5% and 24%, that's still overall a very significant group of horses that have potentially got these fragments to be seen, the relevance to be determined. And we pick them up radiographically in some horses. So this is a case report that Rachel Tucker, one of the lip study authors, myself and a number of other colleagues initially wrote a few years back out of the Royal Vet College, basically depicting the presence of these fragments seen on oblique radiography in a single case, and the fact that you can arthroscopically access some of these, and by some I would refer to the ones that are located very laterally or very caudodorsally, and potentially do something about them. So if we can pick them up, we can see them. It doesn't mean that there aren't options to potentially do things about them. But a case example of just some of the illustrative pictures of what these can look like, and this is one that caught me out, happy to hand on heart and say. So this horse, we detected a C3, C4 fragment radiographically. And even with the best of will in the world looking for these fragments, I missed the C5, C6 fragment on the same side, and this was not subtle. It's not a subtle or small fragment. And I think I'd been tricked into thinking, okay, there's a fragment there, and even still looking for them, they can be really hard to see. Just is the reality of the situation. But we should be looking very carefully for them. And just because a horse has one does certainly not mean it could not have more. I think, why do we miss them? Well, probably because a lot of the time people are not looking for them, either because they don't know that the pathology can be present in the neck, or we underestimate the prevalence. So we're expecting it to be a very rare condition, when the reality is that the prevalence could be up to 1 in 4 horses with neck dysfunction. It could be related to radiographic technique. So exposure, especially in the caudal portion of the neck, could be a limiting factor. Angle-related obliquity, as Lucy's shown from the other radiographic images, if the angle is not correct, you cannot evaluate the articular space or the joint margins thoroughly, then it would be very easy to miss some of these. And likewise, not obtaining obliques, so just doing lateral radiographs, we're tying our hands behind our back. It's no other sort of place in the horse that we would typically look to do that unless we have no choice. And doing obliques, it's really important to obtain them from both the left and the right side and label them. They could be because they're too small. So some of the fragments that we've seen are almost down to 1 to 2 millimeters in size, and I think that would also mimic what was seen in the manuscript by Rachel Tucker and colleagues. Some of them are quite large, as have been depicted, but some are very small. An odd location. So this is a case of mine from quite a long time ago now, that had a fairly sizable fragment associated with the occipital condyle. They're very rare. They're not seen in many horses at all. So if we're not expecting them to be present, it's very easy to overlook uncommon sites, even for a common pathology. And as I've proven satisfaction of search, you can see one thing and become distracted, whether that be one fragment missing a second, or whether that be identifying really profound osteoarthritic change and thinking, perfect, I've got the answer, but maybe not understanding what might be a cause or effect or another significant factor to go with that. So if you have a horse where you've got very unusual articular process joint osteoarthritis, and it's an Arabian or a warm blood, and you're thinking, okay, what do these breeds get? Well, potentially you need to be thinking about looking for fragments that may or may not be causing that. Okay. So spinal cord compression, this is probably the other big thing, really, isn't it? And my first point would be that our radiographic signs that Lucy's described us to use on lateral radiographs, so the dorsal contrast column attenuation and the total dural diameter reduction, that work has not really been done on CT to determine, in comparison with histopathology, if you can do the same measurements. And people may think, well, why not? It's a much sort of clearer image, but the reality is, on a lateral radiograph, you're taking a summed image of an entire curved structure, and it's not clear as to exactly at what point the margins are being delineated. And so I would urge at the moment a fair degree of caution about using the exact same measurement techniques to determine solely as the determining factor for site of spinal cord compression. What in all reality we need to be thinking about doing is probably some degree of cross-sectional area measurements and a subjective impression of lateral, dorsolateral, and potentially ventrolateral spinal cord impingement. And I think if we look back at the horses that were described in the group by Max Christopherson, 85% of horses having spinal cord compression, the vast majority of those horses had compression that was not in a dorsoventral orientation. The vast majority of horses had some degree of lateralized compression. In our population of horses, a smaller number, albeit we had 31 horses where spinal cord compression was seen on CT. And of those horses, only 11 of them were detected radiographically. And the majority of that was because the compression is not always in a dorsoventral orientation, and that's all you're really able to assess on lateral radiography. So it gives you a whole different way of looking at it. And I think at the moment, combining a subjective impression with some degree of radiographic measurements, with potentially some cross-sectional area measurements, are the ways that we need to go, but taking it all with a pinch of salt that more work is needed. And this is one case just to really highlight that point. You hopefully have all seen enough transverse images in the presentation so far to realise that the spinal cord is typically oval-shaped and oval-shaped in this orientation, rather than oval-shaped in sort of a dorsoventral orientation. And this is a C2, C3 intervertebral junction level of a horse with fairly significant articular process joint osteoarthropathy. So a relatively uncommon site to start with. But if we think back to just taking a lateral radiograph, what do we expect to see? And this is a horse where this is the sole site of spinal cord compression with right-sided proprioceptive reflex deficits and associated neurological dysfunction. Well, the reality is nothing. And these are the radiographs of that horse in marked extension and moderate flexion. And there really is, from my eye, not really anything to comment on. Yet this is the site where the horse's problem lies. And so I think if you have a horse where the radiographs are not giving you the answer that you expect, and you have a strong degree of suspicion, think, is it potentially that something else is going on in a different orientation? And whether you try and obtain obliques or ventrodorsal radiographs, I'll leave that to yourselves. But whether we think about CT as an alternative way of picking these up, especially in that warm blood sports horse population where a lot of the lesions are lateralized, then I think that may be where some merit lies. And just to show you what I mean, just a couple of different examples. So 2 different horses here with multiple enemy constructions at C6, C7. We can see some degree of sort of soft tissue proliferation and thickening dorsal to the intervertebral junction here, and we've got dorsal contrast column attenuation. But we've also got this remodeling of the articular processes. You can see we've got some degree of osteoarthritis, an impingement of the contrast column from a lateral perspective as well. So the resulting appearance is circumferential shape change and alteration in the contrast surrounding the spinal cord. And I would say that this is a moderate example, but a significant example nonetheless. Sometimes we have more focal, more marked areas where we've got very clear focal impingement and shape change in the spinal cord. If we follow this right lateral surface of the spinal cord down here, you can see there's clear indentation on both sides. We've got a very sort of clear step in the ventral floor of the vertebral canal here. So if we measured our intervertebral sagittal ratios, we would hope that that may be abnormal and might give us a clue as to the fact that something's going on here. But clearly this is a far more marked case, but very focal nonetheless. Sometimes we can look at a radiograph and say, yeah, I think we've got the answer. I think we can determine that this horse clearly has got a site of severe spinal cord compression, but still we can often extrapolate more information from the CT, reviewing that in multiple planes than a single radiograph will give. It's clear in this horse where the site of the pathology is, but it's not clear to what extent. This is the same horse, C67 in a multiplanary reconstruction, that we've got obvious articular process joint remodeling. This is a 2-year-old horse that clearly shouldn't be present in a 2-year-old, but not only we've got soft tissue proliferation thickening, probably associated with the medial joint capsule recesses on the right and the left, and we've got this marked soft tissue thickening dorsal to the epidural space, so extradural compression here, probably associated with the ligamentum flavum being hypertrophied or thickened. So you get that whole kind of global comprehensive view of not only that what the contrast column around the spinal cord is doing, but what everything around the spinal cord is doing. And just again, a note of caution. So a radiologist with a ruler tends to be a radiologist in trouble, I think is a common saying. And I think that is very fair. Subjective impression is really important. And what we should probably just recognize is that there are all these ways we can look at it and probably be fairly sure of severe pathology. But those horses where you have mild or perhaps moderate pathology, I think we should accept that more work is needed to do cross-sectional area measurements like has been done on MRI to sort of be very comprehensive about our evaluation of this region. And colleagues in the United States have done really nice studies in post-mortem cadaver specimens demonstrating that cross-sectional areas, looking at the vertebral canal area, looking at the spinal cord to vertebral canal area ratios, can be very reliable ways of identifying a site of spinal cord compression compared to histology. And I think that work just needs to translate into CT. It's just obviously hard finding horses that people want to euthanize following expensive testing and let you do histopathology on their spinal cords. But we can do cross-sectional area measurements. It's not a challenging thing to do on CT using, again, commercially available free software. You can do these vertebral canal measurements. I think it's fair to say that they're not directly applicable, and we shouldn't use the measurements that have been published by James and colleagues just yet, because they really were looking at the entire vertebral canal, not just necessarily the subarachnoid space defined by the contrast media. And there's a difference between the slice thickness on an MRI slice and the slice thickness on a CT image and image orientation and so on. So I think we just need a little bit more work to fully understand the extent of how we use CT from a cross-sectional area perspective, but that's probably got the legs for being the future. Okay, so fractures and I think these are something that we do see, as Lucy's also alluded to. These are often visible, or usually I should say visible radiographically if we're careful. But what's also very possible is that we can underestimate the severity of the change, not only in configuration of a fracture. This is an example of a chronic articular process joint fracture, the right cranial articular process of C5, as you can see from the 3D model on the right as well. But also from potentially more concerning fractures such as vertebral body or lateral pedicle fractures, where we might be concerned about the stability of that vertebrae itself. I think the thing with fractures, when we're going down the route of CT, and this does refer to CT under general anaesthesia, is once you've anaesthetised that horse, you're fairly committed to either recovering the horse following the CT with whatever pathology is present, or fixing it under the same anaesthetic. And so it does require a sort of multidisciplinary approach, or really having a client that's on board with you recovering a horse with what may or may not turn out to be a stable or unstable neck fracture. So that's where perhaps standing imaging really could be very valuable. But you can also potentially prove if you've got just a facet arthropathy associated with a fracture, or if you have spinal cord compression, secondary to that chronic remodeling, which we don't really have in this case. I will just briefly, in the interest of time as well, we're running slightly over, and I'm sorry for that. So we'll just briefly mention a few other things. So a lateral occipital joint is a joint that I've already shown with an osteochondral fragment and a defect in. It is possible to have all of the diseases that we see in any other synovial joint in the articular, in the occipital joints, and that includes synovial sepsis in juveniles, so hematogenous septic arthritis. We can see joint effusion if that's asymmetric. We can see condylar remodeling as a pathological process. We can see that that's very asymmetric on the right side in this young foal compared with the left. But it is also very important to note that a really recent study has shown that occipital condyle defects and remodeling can be seen as a normal finding in foals and young horses. And unsurprisingly, the data that you get from a CT scan as compared to a radiograph is far greater. So you can pick them up younger, and you can also see these defects until a horse or foal is older on CT than you can on radiography. So knowing that they can be there and they can be a normal finding is really important, because that's not previously really been described, but also being aware that pathology can occur, osteoarthritis can occur, fractures, subluxations, luxations can all occur, and the weird and wonderful in addition to that means we shouldn't overlook that area. And just briefly, less common sort of pathology. So this is a horse with complete intervertebral disc space collapse. You can see that there's really quite profound hyperattenuation or in essence sclerosis, densification of the vertebral end plates, hyperdense or radiolucent foci in the vertebral bodies. This horse has clearly got chronic intervertebral disc disease of some description. We don't know how it started. It's obviously a very long time ago. But what's quite nice is that you can use myography as well to determine is this a primary osseous problem, or is that an osseous problem with soft tissue neurological components? And that may have relevance both from an understanding of the etiopathogenesis perspective, but also a management perspective. So rare things do occur. This certainly you would expect to pick up radiographically. It was visible in this horse, and there are a couple of short case series and case examples of this pathology out there now. So just very carefully evaluating intervertebral disc spaces on radiography and CT is really important. So I've tried to sort of give examples throughout, just coming back to what CT's taught me and what it's shown us comparing to radiography. But the reality is that with any imaging modality, you're still dealing with the same population of horses, and we should always remember that common things are common. We shouldn't be looking for the examples on the right here where we've got clearly profound congenital malformations associated with severe subluxation, spinal cord compression. In every horse, what we should be looking for are the things that the studies are showing as common: osteoarthritis, and potentially spinal cord compression and osteochondral fragmentation. And that probably how we position the horse's neck for either radiography or CT matters, and obtaining really good quality projections is absolutely vital. I often say that the most important person in the room when taking x-rays of horse's neck is the person holding the horse's head, because that's the only person that can get that horse's head, neck, and the whole body straight, the horse to the square, and standing nice and still for you to obtain good projections. So if you're trying to do that with an owner, emphasizing that point to them is absolutely vital. Probably worth knowing that osteochondral fragments can be really hard to see, and they're probably, as has been shown, by a couple of nice recent publications, more frequent than we've previously thought, especially from radiographic interpretation. So understanding that, knowing that they're there in probably high numbers, means we can look harder for them and potentially detect them more frequently. Knowing that osteoarthritis is something we can see radiographically is great. Knowing that we can identify more about that on CT, lateralize that, localize that more, and understand what that joint is doing is vastly useful information and allows very targeted treatment. But remember, it can also be associated with other abnormalities. So that includes osteochondral fragmentation, that includes spinal nerve impingement, that also includes spinal cord impingement, and that is probably more frequent than in certain populations of horses like warm blood sports horses than we're giving it credit for. And if you're suspicious of a lesion and you're not finding the pathology on conventional projections, just like any other site, you should lesion hunt. Look for the lesions, take non-standard projections deliberately, and ultimately, if your radiographs and your ultrasound are not giving you all of the answers, then absolutely consider CT. And the other way of looking at it is, you can see how much more CT shows you. There is probably merit to CTing the necks of far more horses where we are convinced that is the site of pathology than we're currently undertaking. And it's a relatively low risk, straightforward, quick procedure. You can do this in 30 minutes. That's probably faster than most people can do a series of lateral and oblique radiographs in a standing sedated horse. So, there's multiple ways to look at it, but probably the information you get is of significant benefit. Yeah, and of course there will be zebras. So, this is a really nice postmortem photograph, clearly, of a horse with a fibrocartilaginous embolism, an epidural hematoma and compressive myelopathy. Yeah, absolutely, the rare things in case reports are going to be there, but they're not the common. So look for the common first, and then look for the rare after. And on behalf of Lucy and myself, thank you all for your attention. Hope you're still awake. It's getting late. We've got a drink in hand, and I think this sums up my view of horses quite thoroughly. And we're happy to take any questions that you may have.
Okay, thank you very much, Jonathan, and thank you to everyone for attending. There is a couple of questions on myography that I think we can fill between us, Jonathan. And if anyone has any other questions, if you want to just pop them in the chat box and we can work from there. So the first question was that why isn't ventral reduction of the contrast column thought to be a sign or confirmation of compression? Why are we focusing on the dorsal contrast column?
Do you want me to take that one, Lucy?
Yeah, if you want to start.
So I guess I am very dubious personally about sole attenuation of the ventral contrast column in the absence of either, this is especially on CT, in the absence of either lateral compression or, sorry, I'm going to stop sharing so we can see everyone's face. In the absence of dorsal lateral or dorsolateral compression, I think that it's fairly normal to have some degree of bulging, very subtle bulging of the intervertebral disc space and the respective ligamentous structures in the ventral aspect of the vertebral canal. If you don't have an alteration in the spinal cord shape and there is ample space elsewhere around that spinal cord within the vertebral canal for that spinal cord to move out of the way a little bit, then I am very dubious that that's likely to be a common cause. There are case reports and there are small series demonstrating that that can be a cause of spinal cord compression. So I'm not saying it isn't, but I think that it's very clear in much larger numbers that other sites are far more significant factors, and that's probably where I would personally look. Don't know if you agree, Lucy.
Yeah, I think from a radiological point of view as well, if you're just looking at lateral radiographs, the ventral contrast column does change quite a lot normally with extension and flexion, and certainly in flexion it often becomes very, very thinned where your dorsal stays entirely normal. So I think it's just to be mindful that the position of the neck can change the appearance of the ventral contrast column normally, as it were. The second question on myography is about performing standing myography. And I know that's something that we've discussed a little bit through the process of writing this webinar. And certainly there is one paper that came out of Canada in 2007 that talks about doing standing myography, injecting at the lumbosacral space. And I think they did it in 7 horses. Now, in a reasonable proportion of those horses, to my mind, I think 2 or 3 of those horses didn't actually get as far forward as the cervical vertebrae in order to assess the whether or not there was any myographic signs of compression. And certainly I would be filled with dread at the thought of injecting anything to the spinal canal of a conscious horse that may then seizure. But I will hand over to Jonathan for his experiences of having done these under GA more often than I have.
I am not a fan or particularly keen on trying standing myography. I do regularly do CSF tap standing, ultrasound guided at C1, C2. I think that is really straightforward, and there are a couple of people that have done standing myograms injecting that way as well. Personally, the risks of a myogram are fairly small when in a controlled way under anaesthesia. But when they go wrong in terms of post-myographic complications, things like seizures can be rarely but profound. And doing that in a standing horse with expensive equipment around you, it's an unnecessary thing for me. The risk of anaesthesia, especially TIVA, is incredibly small. Yes, it's greater than sedation, but I value my equipment and my team's safety far more than I would not want to risk a horse having a general anaesthetic. It is my personal view, and I think that you still need the flexion and extension for radiographic interpretation. We do that in every case. We don't just do a plain CT myelogram in a neutrally sort of slightly extended position. We do flex and extended radiographs because that's the only way you can appreciate dynamic instability. And so I've tried to do it in standing horses. You can get really extended radiographs. You cannot get appropriately flexed radiographs in a conscious horse. And so even if you could perfect the technique, I think you're going to miss a bunch of cases, especially in the thoroughbred population at C3, 4, where you're not able to flex that neck adequately to identify dynamic compression. So for me, it's got only limited merit, I think. But if anyone's on the group that is doing this regularly, please sort of flag that, and we'll happily unmute and we'd love to get your experience.
And there's just a couple more questions. One is this being recorded? Yes, it is. So hopefully we'll be able to let the attendees have the recording. Periodically seeing small round mineral attenuating foci within the cervical vertebral bodies. Do we see these, and do we have any thoughts on what they are? I would say I see them less frequently radiographically, but I do see them on CT, and I tend to comment on them and think that they're chronic and not really of any importance. Things like just little bits of dystrophic mineralization, and certainly they're often relatively central within the vertebral body to the ones that I see, and I don't think they're particularly significant. I don't know if you've got any thoughts on those, Jonathan.
On CT, and I guess we thought about reporting them in our case series just as an entity. We don't have histology on them. That was the reason we didn't include them in the end, because it's hard to say for sure what they are. But I think that they've been described as bone islands, infarct, anastosis, like lesions, like everywhere else. I think that the frequency for which we see them and the location, they don't fit with the type of pathology we're expecting the horse to have. And so I think that my view is the most likely and a relatively incidental finding in the majority of cases, but anastosis like lesions seen elsewhere, not necessarily. So we probably shouldn't be too quick to judge, but I think the frequency that they occur, I had a CT yesterday that had 3 in its neck. The horse clearly had spinal cord compression at a completely different site that was not within the vertebral body. So yeah.
Okay, just one final question. Do we have any thoughts on the bone proliferation we sometimes see at the ventral mid-vertebral body of C7 and the caudal end plate of C6 ventrally? It's not something I've particularly thought about. I have seen it previously, and certainly had an interesting case that had it in C3, 4, and 5 last week. I think we came to the conclusion it was probably chronic and incidental to that horse's current clinical signs, and I don't know whether it's some sort of ligamentous proliferation or whether it's just dystrophic mineralization, but certainly it's not something I ever felt the need to put down to be significant pathology, but certainly we see it very rarely, and I think it's difficult to be certain in those cases. Jonathan looks like he's got something to add.
I'm just going to share for the person that's commented. I don't know if you can faintly see, this is a C67 here, and this is a 5.6, so obviously, are you referring to this sort of mineralization that's ventral to the margin of the intervertebral disc within the sort of soft tissues, or is it another site that you're referring to?
I don't have that. Oh, yes, is the answer. So that type of bone there.
The right in this horse was a fairly sort of middle-aged horse, not very old. I think we see it more frequently, but this is just anecdotal, in horses that have that are older, and potentially horses that have some degree of step formation in the alignment of the vertebral canal. Whether it's a sign associated with chronic instability, chronic sort of subluxation at times, or increased movement and just mineralization, dystrophic mineralization of the soft tissues. I think certainly that's possible. I think we see as a separate entity and a very much a distinct entity, we see mineralization within the intervertebral discs, often quite dorsally within the intervertebral discs. And I don't think that's at all the same thing. But I think that we see dystrophic mineralization due to any sort of chronic inflammatory process of soft tissues. I would hypothesize that might be a factor here, but I don't have any histology on cases. I don't get too personally excited about it often. I don't know if that's your experience as well. Again, would be really happy to take anyone else's views.
Okay. So in the absence of any further questions, I'd just like to thank you all for attending this evening. I'm very sorry that we've overrun slightly, but I hope that it's been interesting for everybody. If anybody has got any questions or they go away and think about things and they've got any questions afterwards, please do just email us. The email address is info@vetct.com. So if you do want to get in touch, please feel free to do so. And thank you, Jonathan, for your time this evening. It's very interesting and entertaining talk. So I will leave you all with that. Thank you very much. Good evening, everyone.